Well, today we've seen something very unusual at EASD. We've seen a study published on heart failure, and I've got a cardiologist sitting here with me in the studio. So, Mikhail, let me pronounce your surname right.
Kosiborod.
Kosiborod. Mikhail Kosiborod. Mikhail Kosiborod, you are a cardiologist and you've been responsible for the DAPA FH study. So why is a study on heart failure being presented at a diabetes congress?
That's a great question. So first, just to be transparent, I'm a member of the executive committee for the DAPA-HF trial, and there were many others that have contributed, of course, to the study, and Professor McMurray being the chair of the study and leading the executive committee. But your question is right on, which is why we're talking about heart failure in a diabetes meeting. And I think if you look at what's transpired over the past really 5 to 6 years, is this realization, primarily because of the data coming from cardiovascular outcome trials of glucose-lowering drugs that was mandated by the FDA back at the end of 2008, that it's actually not just atherosclerotic cardiovascular events such as myocardial infarction and stroke that are important cardiovascular complications of diabetes, but in fact heart failure may be as important, if not more important, cardiovascular complication of type 2 diabetes. In fact, if you look at the statistics, heart failure hospitalization is one of the most common events that occur in cardiovascular outcomes trials of people with diabetes. And if you look at case fatality rates, so in other words, the risk of death associated with a cardiovascular event, heart failure hospitalization is the one associated with perhaps the worst prognosis. So I think we've come to realize over the past few years just how common and deadly heart failure is in patients with heart failure. And, when you uncover data like this, which is really impactful, the hope, of course, is that eventually you'll be able to find agents that perhaps treat type 2 diabetes, but at the same time can provide cardiovascular benefit, not just on myocardial infarction and stroke, but also on heart failure. And thankfully, what we can say today is, in fact, we do have data on glucose-lowering agents that, yes, lower glucose, but independent of that effect completely and entirely, appear to also provide benefits, important cardiovascular benefits, including benefits on heart failure.
So just take us through the timeline of all of this. So there's been a number of trials. Just take us through what each found then
Absolutely.
To today.
Yeah, so again, after the FDA guidance came out in 2008, there was, of course, an explosion of cardiovascular outcome trials across different classes of agents for type 2 diabetes. And I would say perhaps the three classes that have been the best studied in the last 10 years since the guidance from the FDA are the DPP-4 inhibitors, sodium glucose cotransporter 2 or SGLT2 inhibitors, and GLP-1 receptor agonists. And what we essentially have seen pretty convincingly now is that these classes of agents are not the same when it comes to cardiovascular outcomes. For DPP-4 inhibitors, essentially I think the best we can summarize the data is that they are placebo-like when it comes to cardiovascular effects. They appear to be safe from atherosclerotic cardiovascular event standpoint like MACE. Some of these agents may increase the risk of heart failure potentially, where others appear to be neutral from a heart failure standpoint. GLP-1 receptor agonists clearly have a benefit when it comes to reducing MACE events. And SGLT2 inhibitors are a very particular class of agents because not only do they appear to have a beneficial effect on MACE, which is modest but clinically important, I believe, and statistically significant, but they also, what they shine is really the effects on heart failure hospitalization, reducing heart failure hospitalizations in quite a robust and consistent way across different patient populations in terms of cardiovascular risk and across different agents in the class. So what the cardiovascular trials and kidney outcome trials have told us about SGLT2 inhibitors to date is that they clearly appear to be highly effective in preventing heart failure in patients, high-risk patients with type 2 diabetes. The questions that was not answered, or actually two questions that have not been answered until now, which is why DAPA heart failure trial becomes really important, frankly, defined heart failure trial become important, is number one, if they're effective in preventing heart failure in high-risk patients, can they also be used in treating heart failure in those patients that already have it? And second question, which is also critically important, what we observed is that these heart failure prevention benefits in diabetes trials appear to be completely independent of hemoglobin A1C and glycemic status. So one of our key hypotheses was that these agents may actually be effective in treating heart failure even in patients that don't have diabetes at all. And so those were the key two hypotheses that were tested in the DAPA heart failure trial. Do SGLT2 inhibitors, and specifically dapagliflozin, do they have value and benefit as agents to treat heart failure, and specifically heart failure with reduced ejection fraction? And can they be effective in treating heart failure both in patients with and without type 2 diabetes?
Okay, so let's take the results of the DAPA-HF trial first. Take me through those.
So this was a large outcome trial, close to 4,800 patients that all had heart failure with reduced ejection fractions. That means left ventricular ejection fraction, which is the metric we use to essentially measure the pumping function of the left ventricle. So they all had reduced left ventricular ejection fraction. They had elevated brain-natriuretic peptide levels, and they were symptomatic. And about 45% of these patients had type 2 diabetes, either previously diagnosed or newly discovered once they joined the study, and about 55% of the patients did not. And these patients were randomized to either dapagliflozin 10 milligrams once daily or placebo. And because it was an event-driven trial, they were followed until at least 844 primary endpoint events occurred. And the primary endpoint was a composite of dying from cardiovascular causes or having hospitalization for heart failure or an urgent visit for heart failure that required intravenous therapy. The median duration of follow-up was about 18 months. And what we observed were the events were very, very high in the placebo group, indicating that even in patients like this, who were, by the way, optimally treated with what we consider state-of-the-art, guideline-directed medical therapy for heart failure, the event rates continue to be very high. And those event rates were significantly reduced with dapagliflozin by 26%. So the hazard ratio was 0.74, 26% relative risk reduction, highly statistically significant, with the curves for the two treatment groups diverging very early after randomization. And importantly, I would say not only was the composite outcome of cardiovascular death or hospitalizations for heart failure reduced, but each of the components of that composite were independently reduced. So worsening heart failure episodes were reduced by 30%, and the cardiovascular death was reduced by 18%, both independently statistically significant. What's more is that not only did the compound reduce the risk of death and hospitalizations for heart failure, it also made patients feel better. It actually reduced the symptomatic burden of heart failure as well. And the safety profile looked very, very good. In fact, there were a lot of potential concerns about using hemodynamically active agents like SGLT2 inhibitors on top of beta blockers, MRAs, loop diuretics, renin-angiotensin, aldosterone blockade. But what we observed in terms of safety was actually quite unremarkable. In fact, well, it was unremarkable because there was no imbalance, really. There was no meaningful differences in safety events between dapagliflozin and placebo group, which you could argue is actually quite remarkable because it's such a sick population of patients that are already being intensively treated.
So the New England Journal of Medicine has done a concurrent publication, and there were a couple of things that they raised, which actually I'd like to raise with you.
Yeah.
So, for instance, they say almost all the patients had moderate heart failure, so the benefit and side effect profiles with more severe heart failure will need further study.
Well, I think we studied symptomatic patients with heart failure. About 2/3 of those patients had New York Heart Association Class 2, and 1/3 of those patients had New York Association Class 3 symptoms. I think the best way to interpret the results, in my humble opinion, is to look at the entire patient population. The best estimate of the treatment effect is always on the entire population. And I think in the entire population, the results were just like what I mentioned earlier. There was a clearly clinically meaningful and statistically significant benefit. So, will it be helpful to have additional information from other trials with other agents in the class in a similar patient population and take a look again at what happens based on severity of symptoms? Yes, I think it'll be helpful. But I personally, on the clinical side, I would argue in my practice, it would not deter me from potentially using one of these agents, certainly if the patient has diabetes, because that's an indication we have today. if they had more severe heart failure symptoms like NYHA class 3. Now, what we don't know is what happens in patients that have really severe decompensated heart failure who are in the hospital, because those were not included in the trial, or what happens in patients that have such bad heart failure that they need a left ventricular assist device or potentially a pre-transplant. Those patients weren't included really either. So, or if they were, there were very few of them. So I think, we cannot necessarily extend the findings of WHF to those, very, even within heart failure population, very ill patients, and it may be helpful to collect more data on those patients in due time.
Now, the New England Journal of Medicine commentary said that this is a very important and impressive set of results. And one of the things that they finished their commentary with, which I think is very interesting, particularly for all of you treating patients daily, is that so they recall the Paradigm heart failure trial and showed very clearly that combination drug was more effective, but in 2017, and that was published in 2014, there are fewer than 15% of eligible patients receiving that drug.
Right.
And they raise the issue that, will we be waiting as long, or will patients be waiting as long to be receiving this drug for heart failure? I mean, it's a really important point.
Well, it is a really important point, and my answer to that question would be, I certainly hope not. I hope that we're not going to be waiting this long to implement this highly efficacious therapy for patients that have very high symptom burden and very high risk of morbid outcomes, repeated hospitalizations and death from heart failure, where the event rates are extremely high, as what we showed in the DAPA heart failure trial in the placebo group. So I hope we're not going to be waiting for very long to implement this. Now, from an implementation standpoint, it's really, really important, because if we do wonderful trials and we demonstrate wonderful results, but they're not implemented in clinical practice, that we have not really done due diligence and have not served our duty to our patients, right? In people with diabetes, we can start using these medications in those that have diabetes and heart failure today because they have an indication. In patients that don't have diabetes, we'll need to wait for the regulators to weigh in. And my hope, certainly sincere hope, would be that we will be able to use these agents in future in patients that don't have type 2 diabetes. But today in our practice, if they have diabetes, we have a highly efficacious treatment that can really improve patient outcomes, reduce the risk of death and hospitalizations, make patients feel better with very favorable safety profile. Now, there are always, of course, issues with implementation, but we better figure out how to translate the clinical trial evidence into practice without having to wait for years and sometimes decades for that to happen, because I think at the end of the day, especially with highly efficacious treatments, the people that end up on a short end, unfortunately, when it takes that long for us to implement it, is our patients.
And as you suggested, the number of heart failure patients has been growing enormously, partly because medicine has been so successful at preventing death from MIs, that actually we've created a population of patients who will then go on to have heart failure. And until relatively recently, the number of treatment options for heart failure were really quite limited, weren't they?
Yeah, no, so I would agree with you in the first point, which is the number of patients with heart failure is growing. Partly, I think, because we are doing a better job in keeping patients alive and healthier for a longer period of time after they had a myocardial infarction. Partly because the population is aging, partly because the prevalence of chronic kidney disease is increasing, which is a big risk factor for heart failure, partly because of the diabetes and obesity epidemics that we're experiencing, which are also big risk factors. So the bottom line is, unfortunately, heart failure is not going anywhere, and we better figure out better ways of preventing it and also a better way of treating it. And you're also absolutely right that until relatively recent future, talking about a couple of decades ago, our treatment options for heart failure with reduced ejection fraction were very limited.
Cool.
Now we have multiple drug classes that are highly efficacious in treating those patients. We still have a segment of the heart failure population for which we don't have a lot of treatments, and that's heart failure with preserved ejection fraction, where we have very limited treatment options. But I would argue there is definitely room for improvement on both sides of the equation, because even in optimally treated patients with heart failure and reduced ejection fraction, as we showed in the DAPA-HF trial, the risk is still extremely high. So we still can improve quite a bit, and this is one step towards that direction. And in heart failure with preserved ejection fraction, there are actually trials going on with SGLT2 inhibitors as we speak.
So we've covered the DAPA-HF trial, but what about the DEFINE trial? Do you want to add something about that?
Yeah, so DEFINE was also a dapagliflozin trial in a very similar patient population with heart failure and reduced ejection fraction, both with and without type 2 diabetes, even though the proportion of patients with diabetes was a bit higher in DEFINE, it was about 60%. And it was a smaller trial, under 300 patients, and it was all in the United States, 26 sites in the United States. And what we try to accomplish in a defined heart failure trial is understand the early effects of dapagliflozin as compared with placebo on the symptom burden, physical function, and quality of life in patients with heart failure. And I think what we can say based on defined data is that there was a clinically meaningful and significant benefit in terms of improving the health status of patients with heart failure with dapagliflozin as compared with placebo, and that benefit emerged early within 12 weeks of treatment. So if you put these two together, I think what you can say is dapagliflozin reduces death, it reduces hospitalization rates, and it improves, makes patients feel better, essentially reduces symptom burden. And those are very debilitating symptoms in patients with heart failure, and it appears to do so early, within 12 weeks, and those benefits appear to be sustained long term. And I think that's an important message, and when you add a very good safety profile on top of that, it makes it clearly an option that I think we should, of course it's a novel option for treatment of heart failure, right, because completely novel mechanism of action, something we hadn't used for heart failure before, so I think it's a overall very exciting data that I hope will have a big impact in terms of clinical practice in due time.
And of course, it's diabetologists who are teaching cardiologists.
Well, I think we frankly are teaching each other and
All right then.
Learning in the process.
I'll go quietly. But thank you very much indeed. I mean, this is really, it's very important work. It has immediate and clear benefit for patients. And once again at EASD, this is changing the textbooks in terms of how patients should be treated. So thank you very much for being with us.
My pleasure. Good to be with you.